The latest to be released, melatonin agonist as agomelatine. I'm not so sure it's available in my hospital. I don't know whether it's available in IMH. Is it available in IMH? Not really. It's very new onto the market, okay? For those who cannot sleep, we give agomelatine. I think the maximum dose is 50 milligrams, valdoxan. 50 milligrams maximum. Start with 25 and up to 50. Now, what about depression with physical health problems? This CPG is good in that it talks about real-life situations. For example, if you have a person with a lot of medical problems together with depression, what shall we prescribe the patient? Now, we want to take into account the presence of additional physical health disorders, side effects of antidepressants which may impact on the underlying physical disease. For example, SSRIs may cause hyponatremia, SIADH, and so on, and interaction with other medicines which the patient may be taking. Now, if the patient does not respond to the SSRI, you may want to switch the patient to another drug rather than adding on something else. The earlier speaker was talking about trying to discourage polypharmacy or combination therapy. So this guideline for depression also stresses that it's good to switch to something else. But in the process of switching, we want to taper down the original medicine first, start the next medicine, and then taper off the other one, the first one. When switching, be vigilant for drug-drug interactions, such as serotonin syndrome and a drug discontinuation reaction. Now, if you refer to Annex 6, page 64 to 66, there is a table there from 64 to 66, a very good table in Annex 6. So I commend to you to read at the end of this talk. It's a very, very good table on how to switch from one drug to another. Well, what about suicidal thoughts and antidepressants? Actually, it made a lot of headlines that antidepressants were associated with increase in suicidal ideas and so on. So that's why it's important, especially in children, adolescents, and young adults between the ages of 18 to 24, to monitor very carefully within the first 1 or 2 months. The reason is this, SSRIs are very alerting. And so you have a patient who's very depressed, feeling hopeless and suicidal. Before their mood can improve, the energy levels have already come back due to SSRI treatment. And so that propels them, gives them the energy to actually kill themselves. So it's very important. SSRIs can also be associated with some restlessness, akathisia-like type of symptom. So be very careful, especially in a young depressive. Now, it doesn't mean that SSRI cause suicide. We don't want to raise the alarm. It's associated with more suicidal thinking, but it doesn't cause suicide because there are hundreds of thousands of patients in 2 studies in America. The population of the patients studied is about 100,000 for each of the studies, showing that SSRIs actually reduce suicides, improve depression, and reduce suicide in the long term. But we still have to be careful because there is a black box warning with regard to SSRIs and suicidality. It's just to be careful, that's all. What about the duration of treatment? It says here that all antidepressants, once started, should be continued for at least 4 to 6 weeks. Why is that so? Because antidepressants take about a week, 2 weeks, 3 weeks to work. And by about 4 to 6 weeks, it should have worked. If it's going to work, it should have worked. So if you don't see any response, first week, second week, third week, just keep on going. Okay? Unless, of course, the patient is getting more suicidal, cannot tolerate medicine, then you decide to switch or to refer the patient to the psychiatric clinic, to the psychiatric hospital. But it may not work before the end of 6 weeks, so just keep going. It should work by first, second week. If it's really going to work, it should work. Now, how long to treat for? The guideline says, and this has got very good grade A and level 1++. First episode without psychotic symptoms, you should treat for 6 to 9 months after remission of symptoms. I underline the word after. It's not that the total length of treatment is 6 to 9 months. It's when the patient has gone into remission, symptoms have gone, continue for another 6 to 9 months. The reason, if you stop too soon, the patient will relapse. Okay? So don't stop, don't be in a hurry. Even when the patient is well, tell them to go for another 6 to 9 months. Tell the patient that chances of relapse is great if they stop too soon. What about second episode of depression? Go on treating for another 2 years, 1 to 2 years, okay? What about 3 episodes? 3 years or more, or even lifelong, okay? So it's very easy to remember. First episode, 6 to 9 months. Second episode, 2 years. Third episode is practically lifelong because the chances of recurrence is very, very high. What about combination benzodiazepines and antidepressants? Very often we combine both. And it's been shown that it's good to combine them, especially where there's presence of anxiety, agitation, and insomnia. So it's very good to combine. Short-term usage is good. This systematic review found that patients with combination were more likely to show response in the short term. That means within 1 to 4 weeks, their response was early. Okay, quick response, quick onset of action. Because as you know, antidepressants take some time to work. So when you add a benzodiazepine, it makes the onset of action much quicker. But the gains made by this combination group is not going to be long-lasting because by 6 to 8 weeks, those treated on monotherapy antidepressants would already have caught up. So you see, the gains are not really sustained, it plateaus off, and those who are on monotherapy antidepressants would have already caught up with the combination therapy group. So to be useful is within the first few weeks when you combine antidepressants and benzodiazepines. We always mention the risk of tolerance and dependency and withdrawal and so on when we use benzodiazepines, so we're very careful. And also there's MOH guidelines on the use of benzodiazepines, and you don't want to get into trouble. So we also put this in, that you be careful when you use benzodiazepines to use it very sparingly, to encourage the patient to take it on a PRN basis. What about discontinuation of antidepressants? Slowly taper it down, because if you taper down too quickly, once you stop it too quickly, you're going to have withdrawal symptoms. Now, this guidelines doesn't have anything new to add with regard to psychoeducation, psychotherapy, cognitive behavior therapy, interpersonal therapy, couple or marital therapy, or ECTs. The same as the previous guidelines. The only thing new about ECT is that it says here, ECT may be considered when rapid response is required, for example, in pregnancy, comorbid medical conditions that preclude the use of antidepressants. So a patient is very sick, they can't take the side effects of antidepressants, maybe because antidepressants also interact with their concomitant use of other medical drugs. So they just go for ECT, which is safer. In fact, ECT is safer than antidepressants. I recommend you to read the chapter on ECT because it tells you what are the contraindications. Very, very few contraindications, actually. But we always have to liaise with the anesthetists and medical colleagues or surgical colleagues if there are any comorbid medical surgical problems, so that they clear the patient, they say the patient is safe, then we can proceed. The last person to agree to would be the anesthetist, because if he refuses, then we can't proceed without him anyway. So it's very important that we get an anesthetist to agree that the patient is safe to go under GA.